give us an insight into a year in review of lupus, we have with us Dr. Rakesh Kumar Pilania, Assistant Professor, Department of Pediatrics, PGIMER, Chandigarh, and Joint Treasurer for Indian Society for Kawasaki Disease.
So good afternoon all, and thank you organizers for providing me the opportunity to learn pediatric lupus in last 1 year. So I must congratulate the scientific committee to think about this session, and there are several sessions like this. I don't know how much you will benefit, but I have got several benefits of this, making this presentation, because I have learned a lot when I started making presentation in last 1 year. How can we, what is the pediatric lupus, new things. So when I started making presentation, I thought that I'll start Googling, and when I went to the PubMed, I put just lupus, and 1 year filter there was 4,787 articles. Then I thought I will put a pediatric lupus, then it was 500 articles. I thought it's not an easy task. I asked my colleagues, friends, senior residents, what should I do? Can you just tell me the few articles which I'll do, so that people should know that what is what should be the take home message from this lecture. So the outline of this presentation is that I'll discuss few things like clinical science, because we have, at the end of the day, we will go to the patients. And then the basic science, because the basic science will make us to learn that all patients are not same actually, and basically we have to learn which patients to target like that. And there are several novel discoveries in last 1 year or 1.5 years that suggest that pediatric lupus is not a one disease. Basically it's a syndrome, and we have to look into more in these patients, and this treat to target, this word is there in from last 8 years, but we as a pediatric rheumatologist has started learning about this treat to target in our diseases from last couple of years or more than that. So as a clinician, I'll start with one basic clinical study which published in Blood from, this is a French cohort, and what they have shown is that, because we deal this in day in and day out, because whenever we are dealing with autoimmune cytopenias, children with autoimmune cytopenias who has ANA positivities. So how many of them can develop a lupus as when they are in follow-up? So what is the most important is that they have followed the 355 patients with autoimmune cytopenia, those who had ANA positivity, and out of that 79 had developed lupus. So the most important thing is that most of the children who are Evans syndrome, which is in red, and then in green is more of autoimmune hemolytic anemia, they are at presentations are as a part of lupus. But in chronic ITP, the SLE-free survival is decreasing over the time. That suggests that we have to follow up these patients with chronic ITP. They may not be a chronic ITP, and their ANA they have to be monitored for long-term follow-up, and few of them will be developing the lupus on the follow-up. So the take home of this study is that SLE occur in 22% of children with ANA associated autoimmune cytopenia, and children of age more than 10 years and ANA titer more than 1:60 must be monitored for long-term development of lupus, specifically when we are dealing with chronic ITP. Going into the second study is that this is a CARA group study, which what they have done is that we all know that CARA has developed consensus treatment plans, CTPs, in a long back. So what they have compared is that we know that NIH protocol versus Euro-lupus protocol, and NIH protocol, we were knowing that this is a more toxic protocol because of that higher dose of cyclophosphamides. So what they thought of comparing is that over the 10 years, how the children with lupus nephritis behave when they are receiving NIH protocol versus the low dose Euro-lupus protocol, and they have compared the complete response versus partial response over the 12 months follow. So this is a basic comparison study, and most of the things were similar, but except that Euro-lupus patients were on average older at the start of current cyclophosphamide therapy, had longer disease duration, and more commonly had relapsed or refractory lupus nephritis compared to with NIH group. But over the time, both group has behaved same, and in comparison, both in new onset lupus nephritis and relapse or refractory lupus nephritis, both both regime has worked well. So that suggests that possibly we can use Eurolupus protocol as in children with childhood lupus nephritis. And one more important highlight is that despite use of cyclophosphamide, childhood lupus is a difficult disease, and despite the use of cyclophosphamide, there is a significant disease activity and damage in these patients. We use lot of steroids, and we have to know that steroids are not like, we have to quantify the glucocorticoid toxicity, and this study from the Boston group has suggested that, and this is a scoring system which was initially a glucose toxicity scoring system which was in adult, and then it was modified as a pediatric glucose toxicity, and this is a composite instrument with a core index encompassing the weighted constant time is in 10 health domains. And what is the most important highlighting part is that more than 50% patients had hypertension, mood disturbances and sleep disturbances. So, and over the years that glucocorticoid toxicity is increasing. So, the highlight of this paper which I thought of that we have to look into this, we have to monitor these patients for the glucocorticoid toxicities. Changing the gear to the antiphospholipid syndrome, and I just wanted to sensitize you that we have new guidelines to classification of the ACR-EULAR classification, and if you will see that this flow diagram, this is a more of similarity to the ACR-EULAR classification criteria for lupus, that we have now an entry criteria for antiphospholipid antibody syndrome. Just to highlight that we all know we were using the Sapporo criteria 99 and then revised 2006 Sapporo criteria, and this criteria suggests that there are clinical criteria listed as a domain 1 to 6, and these include macrovascular thrombosis, macrovascular venous or arterial thrombosis, microvascular changes, and then hematological manifestations. And so what is highlighted is that even if you are having a thrombocytopenia, which you can say that it is because of antiphospholipid antibodies positivity, then you can classify the patient as an APS. So you do not need as a thrombus or obstetric complication which was there as a previous classification criteria. But the caveat is there that how can you classify that if thrombocytopenia is just because of the disease, lupus, or because of APLAR, that would remain the important part. This again from the same group, I would say that Doru Kerken is from the Cornell group, and what they have followed is a pediatric loop, APLAR. So they have classified their patients into the two groups. One is high risk APL profile, that is include initial LA positivity or high titer antibody positivity, and low risk including the LA negativity or low titer antibody positivity. So what is important is that initial high risk APL profile was persistent in approximately 90% of patients, while of those who had 32 patients who had persistently positive APL, almost 1/3 had high microvascular thrombosis, and more than approximately 50% has non-thrombotic APL related complications. So that means that persistent APLA positivity is a very significant thing, and we have to follow the children in a different way. Transcriptomics is coming in a big way, and we all know that and why it is essential that we should know about this. So this is a transcriptomic signature study from the University of Hong Kong, and what they have done is that they have classified the patients into the two parts. One is SLE active patients and SLE remission patients, and they have compared with healthy controls and performed the transcriptomic profile of SLE patients. I don't want to confuse with so much of colors, but I just want to highlight your focus on the molecular signature in the SLE patients in different disease states. So if you will compare, there are three parts of this color status, and in active patients and remission patients. So in first part, if you see that there is a down regulation of the molecular signature, and which has recovered in the remission patients, while in second part there is a up regulation of these genes, and then that has down regulated, and while in third part you see that those genes are remain upregulated during the both active and remission patients. So why these genes are behaving in a different way? And if you will just classify and you will do the mapping of these things, and what elegantly these people have done is that if you the persistent up and recover down, if you divide this, and persistent up is a part of more of interferon pathway and transcriptional regulation, while cell cycle related and immunoglobulin plasma cells related pathways are recover downs. And what we use commonly in the children with lupus, these MMF, methotrexate and corticosteroids, they reverse the expression of the recovered gene, not worked on the persistent up. So we have to work on these, that how can we control the persistent up module expression, and these suggest that there are several targets based on the CMAP databases, which is like now we can correlate the available novel therapeutics, and there are several molecules which has been applicable in these situations. So we have to work more in control of the disease activity. Possibly there are several things to learn. So further, this is a small study just to highlight that this is a study from China, which they have done is IGRA, they have used it, and IGRA is a novel biomarker for pediatric patients with systemic lupus erythematosus, and they have compared with several markers, simple markers like dsDNA, complements and other things, but the ROC curve is almost equivalent to complement C3, C4, ANA. So may not be easy to done, but wherever it is available, you can think of as a marker of disease activity. But this is a study just to highlight that DNase 1L3 variants. This Stefano Volpi from Italy has reported 3 patients with DNase 1L3 variants, and they have reported as a lupus nephritis pattern. More important is that if you can see the important part, that all 3 patients had developed a kidney failure. This is a significant severe disease. Whenever you are having a DNase 1L3 variants, the chances of developing kidney failures are very high, and it is reported. So what they have shown is that DNase 1L3 related can present with the refractory lupus nephritis, and these patients in tissue settings, they have highlighted the interferon signatures, and possibly the DNase 1L3 related glomerulonephritis is a spectrum of interferon mediated kidney disorder and provide the rationale for interferon targeted therapies in these settings for these patients. Further, that we all know that about the type 1 interferonopathies, and probably in the years to come, monogenic C1q deficiency will be classified as a type 1 interferonopathy, because although we know that it's a complement mediated disease. And this, we as a clinician for the PG residents, whenever we are dealing with C1q deficiency, if you will see the clinical ANA profile, most of the patients are dsDNA negative except 2 or 3 patients. Almost all patients are having a CNS manifestation. And this is a very important. In C1q deficiency, the subtle CNS manifestation would be there in initial, and most of the patients in our cohort also had. But important finding is that if you compare the interferon signature in comparison to the canonical interferonopathies like TREX1, and these are the classical interferonopathy, the interferon score is almost equivalent. That suggests that we are dealing with the disease which has a significant interferon signatures, and we have to treat them differently. To start with the novel discovery, I will just share the 2 novel discovery which has come in last 1 years. This is a haploinsufficiency in PTPN2 lead to the early onset systemic autoimmunity from MAMS syndrome from the lupus. This is a French group who has done this study, and we were knowing about the PTPN2 as a causative of the inflammatory bowel disease or combined immune defects. But here in this, they have described the 6 patients, 1 patient with lupus and 5 patients with MAMS syndrome. And on this paper, the commentary is published by the Joshua Tobin and Megan Cooper. And I will encourage you to read, because this is a very beautiful commentary just to say that PTPN2 deficiency. PTPN2 is basically a negative regulator of the JAK-STAT pathway, and it's act as a phosphatase, and if it is not working, then JAK-STAT pathway will be hyperfunctional, and these patients will, there is a role of like the JAK inhibitors in these patients. And the elegant experiment by this group has described the role of tafasitamab in these patients in the cell lines. A couple of years ago, we know that we have learned about that TLR7 gain of function genetic variation causes human lupus, and this was published in 2022. Because related to this part, we have other monogenic lupus, and we know that TLR7 gain of function or TLR hyperfunctioning will lead to the autoimmunity, and there is a two seminal papers from the Nature Immunology and Science Immunology by the Seattle Masters and German group. What they have highlighted is that genetic variants in ANK93B1 predisposed to childhood onset SLE. So why it is important is that again that ANK93 act as a chaperone to facilitation of the TLR7 signaling, and if there is a loss of function of N93B, which lead to the increased interferon signature, again highlighting that role of interferon in these patients. And this study described the novel phenotype of the monogenic lupus. How can I complete the lupus presentation without explaining the basic studies from the India? And my dear friend Sagar has published this study from the south of India about the monogenic lupus and lupus nephritis phenotype. What they have also shown is that C1q deficiency was the most common cause of monogenic lupus, and PK, protein kinase C delta defect and CGD mutation were seen in one patient. So again highlighting that we have to work these patients for more of monogenic lupus. So I'll just focus here that we all have been taught that whenever there is a dsDNA positivity, it is associated with more of lupus nephritis. But again, in this also, dsDNA positivity was not associated with more of significant as a lupus nephritis. Why have highlighted the taking clue from this, that anti-dsDNA and anti-C1q autoantibody has been thought of that it is linked to the lupus nephritis, but possibly they are more of confounder, and there are several new antibodies which are more related to the lupus nephritis, and like anti-enolase and anti-histone IgG2 were, and serum level of anti-ENO and anti-HG2 level were measured in the follow-up of patients for designing the length of therapies. So these are the new upcoming things and the autoantibodies of the lupus nephritis in the patients with lupus nephritis. We know that more than 90% or 90% of patients with lupus are polygenic. We will be talking about the monogenic lupus, but the 90% are polygenics, and whether the polygenic or single nucleotide polymorphism also have some role in the pathogenesis. So this is a nice work from Boston by Peter Negrovic. What they have done is that they have done single GWAS SNP-seq, and what they have identified is that they have identified 5 SNPs, and out of that 1 SNP they have studied in detail. That means that this SNP with RSID has role in the increased chances of affinity of the ECOROS relating to the type 1 interferon signature. So again, which disease has a polygenic or has a role of defect of SNPs has also lead to the coming to the treat to target. Because tomorrow we have to go to the clinics, and that would be the most important role. Why we need a treat to target in childhood lupus? And I would say that it's more required comparing to the adult lupus, because we have a more higher disease activity, more widespread and severe organ manifestation and medication burden, and higher incidence of renal, cardiovascular and neuropsychiatric involvement. So treat to target is that we have to set the targets. Before that we had a target that complete remission or clinical remission. Now the targets are changing, and why it is important that to know the targets. So the committee has given the 4 overarching principles. The common thing is that we have to take a shared decisions, we have to know the targets, and the management of childhood SLE requires an understanding of its diverse manifestations, and patients with childhood SLE requires a regular and long-term follow-up. There are points to consider. There are several points. I will just focus on 2 or 3 points. That the treatment target of child SLE should be disease remission. That we all know. But the second point is, in patients where remission cannot be achieved, low disease activities and alternative targets. This is a very significant development which has occurred in the last couple of years, that lupus low disease activity is a new targets, and possibly we may not run behind the complete remissions. The fourth point is the patients with clinically inactive disease and persistent low complement or elevated anti-dsDNA antibody titers required close monitoring. It may not be prudent to escalate the therapy on just based on the labs. Actually, we have to treat the patients. So taking to the clue from this, that this is a study published in Lancet and by the Asia Pacific Lupus Collaboration Group, and they have followed the patients with the lupus low disease activity state, and that any duration of sustained lupus low disease activity or remission longer than 3 years has been associated with reduced damage accrual or flare. But it is important to highlight that sustained DORIS remission or steroid-free remissions were less attainable in comparison to the lupus low disease activity. So can we satisfy ourselves with lupus low disease activity? And this study from the China can give some clue that even if you are having lupus low disease activity in comparison to remission, the damage would remain same. So possibly we can follow as as organ damage in the remission group was similar to that in the lupus low disease activity. So possibly that can be the next target for the disease activity. We all know about the CAR T cell therapy, and I will not discuss because we have yesterday an elegant commentary from one of the faculty. And but this is the possibly future of the lupus when we are dealing with one drug, two drugs, and multiple drugs we are giving, and the disease refractoriness possibly we will be having in several years. And I'll finish my presentation with this apt review by Professor Amita Agarwal ma'am, that childhood and onset lupus, there are international perspectives. So we have several barriers: long transport distance, lack of rheumatology training opportunity, and lack of access to pediatric rheumatologists, lack of research infrastructure or cost of therapeutics. But we have several solutions also, and possibly there are several facilitators to overcome these issues. And I will encourage you to read this beautiful article. Thank you all. Hope you have enjoyed this talk, and I will just invite you at our JAN program. This is a global initiative of academic network program by Ministry of Education, and we are doing this in March 22 to 22nd on the Kawasaki disease. Thank you.